I'm very sorry, Dr. Sushmita. Incidentally, you became the last speaker, and thank you. I know you'd be a great sport and you'll take it along. And you have to talk on preferred practice guidelines for childhood glaucoma.
Yeah, thank you so much, Dr. Chitra, for having me in this wonderful session. So, childhood glaucoma is a lot like glaucoma. It's similar on the surface, but believe me, there are countless hues beneath. So, if I could just list the challenges, they're difficult to examine because you don't know what they have. All of them look very similar. It's a surgical disease, and surgery is difficult in these tiny eyes. Post-op follow-up is not easy but required, and we need repeated GA. And the goal is not target intraocular pressure, but the goal for us actually is target vision. And it's not an eye we are treating, it's a whole family. There's genetics, there are other siblings, and there's the life of the child itself. So if treated in time, this is probably one of the earliest that we have, a couple of hours old only, and she grows up to be a normal child going to school as any other. So why is it important knowing what they have? Because most present with the cloudy cornea. For instance, an acute hydrop. So this needs surgery early, and a combined trap with trap would be the best. A neonatal onset CU. If you recognize this, you have to prognosticate to the parents that this is a bad intractable glaucoma requiring multiple surgeries. Visual outcomes are poor, and usually they are homozygous for a recessive disease, so each parent is a carrier. Congenital primary aphakia, do not touch. The first one that we had, which led us on this journey, and we realized that this is not a simple anterior segment dysgenesis. You touch these eyes, you do incisional surgery, 100% phthisis. So recognize this condition. Congenital rubella syndrome, if you don't recognize glaucoma in a small eye. So if there's no ophthalmos and yet there is optic disc cupping, put in a UBM. If you see the cataract, 9 out of 10 times it's rubella. Why that's important is it's not just the eye, there's hearing, there's heart. I've had a child with developmental delay until I recognized what it was, and when the eureka moment came, that poor kid just couldn't hear. So all they require is a BERA and a hearing aid, and they're as good developmentally as anybody else. So don't write them off, and they are a problem for newborn glaucoma, which we don't know. UBM has been a game changer. It characterizes the glaucoma. Peters anomaly comes up very well with the desmets defect. We've recognized corneal clefts. We didn't know what these look like. They're actually clefts in the corneal stroma itself. Sometimes it was so puzzling because the pachymetry showed very thin corneas until we recognized that it's because you were measuring only part of it. And if you recognize that, you do the surgery, you have a decent periphery, you can do an optical aeridectomy. Achoria due to Exenfeld rigors, a lot of these achorias we would just write off until we recognize that they're actually detached Schwabe's line which carry the iris along with it, and a simple pupilloplasty can actually change it. We've also seen desmets defects which are so large that the lens is actually in the cornea. These are eyes which you don't need to really chase because uniformly they do bad. I've talked about congenital primary aphakia, again UBM, dysgenetic cornea, dysgenetic trabecular meshwork, and not developed ciliary body. So it's a very, very complex disease. Surgery is difficult but important to decide what to do. If it's PCG or any other non-acquired developmental glaucoma, angle surgery would be our preference. If you can even see the iris insertion through a hazy cornea, they do very well. Acquired glaucomas in children usually require a trabeculectomy with MMC. The angle surgeries don't work so well. Post-op follow-up requires repeated GA, but you need to recognize that there is an association between repeated general anesthesia and cognitive decline, which is what we went ahead and considered sedation. Intranasal dexmedetomidine has worked very well for us. It precludes anesthesia in a lot of children, and we just need to put the child to sleep, and that's all that we do. So the things to look for, yes, we are dealing with glaucoma, so it's IOP, but it's also cornea and it's also the axial length. So these are equally important because in an elastic eye, you could have an enlarging eye under the influence of raised pressure, and you will not be measuring that pressure as high. So if you are not looking at the axial length, so rebound tonometry is, the eye care is commonly used. The baby, by the time they're in the mother's lap, there's nothing that we need to do. Maybe you have somebody just ring a bell behind and they are fine. But remember, GAT in awake children is still the most accurate method of IOP measurement. Don't run away with just doing eye care and nothing else. Rebound tonometry often overestimates IOP, especially if it's more than 21 millimeters, and overestimation also increases with increasing CCT. So we've talked about this, the IOP being normal with the axial length. So this preterm baby with ROP underwent an LIO and then required a left lens sparing vitrectomy. Post LSV, she had ophthalmos. Now they had been checking pressures, but they'd not been checking axial length. So the pressures were consistently normal until they noticed this ophthalmos and sent her to me. The pressure was still normal, but there was no question that this eye had glaucoma. This is something which, this is Sampoulis's graph of normal intraocular pressure. We use this growth chart routinely. It's part of our pediatric glaucoma file. And I would say it's helped us so much because we chart the growth according to this growth curve. And you can see for this baby, it went up till there until we did the CTT, and then it actually stabilized. So the pressure was out of the equation for this child with glaucoma. You can see the cornea having cleared and the axial length having stabilized. So that's just one caveat. When would we start thinking of doing an EUA? We usually have cut down on it with the eye care and axial length. I'll take just 10 seconds more. And anyway, so if the axial length is continuously rising, if the IOP is high, but if you're doing angle surgery, suture removal. During the COVID time, we've lost one eye to suture infiltrate, panophthalmitis, and it had to be eviscerated. So suture removal is our huge reason for doing an EUA after goniotomy or an angle surgery. Just to touch upon a novel idea of propranolol, sometimes you think out of the box. It's helped us in these kind of horrible exudative sturge-Weber's. We haven't seen it after that, so we are happy that it happened. The lessons beyond glaucoma is that babies have a life, they live it fully despite huge odds. The babies are parts of families. These are 3 generations of Axenfeld-Rieger and a whole family of Anaeridae except the dad who doesn't have it. So the real lessons are of patience, hope, and gratitude. I'm just sharing this too. This is a child with congenital primary aphakia. All they need is aphakic glasses and a limited DLCP, and the fellow is as naughty as anybody else, but we are happy that we've now recognized them and he can do what we want. I've passed the madness along to my senior residents, and this is my team. Thank you very much.
Thank you so much. That was a most motivating talk. And one question, because we are yet to start. What would be your target IOP in childhood? Maybe 15 or less you would say is okay to let the child be?
For newborn children, the normal intraocular pressure is low teens. It's about 12.
Oh.
So 15 would be high, and definitely not the less than 21. But like I said, the intraocular pressure that you measure might be 12. But if the axial length is increasing or horizontal corneal diameter is increasing, then that pressure is not being reflected. It's like a balloon. So you push it, it will never be hard.
Any role of GAT in children?
Of?
GAT.
Goldman? Goldman applanation?
Yes.
Yeah, Perkins is the standard.
No. GAT procedure.
Yes, of course.
Yeah.
Anytime. If I have a child now, it's almost always GAT if I have to do an angle procedure, because it helps me not requiring to